for sure. But yeah, I've done a lot of consulting in long-term care, assisted living, group homes, those type of things. A little bit more psychiatric facilities in the last few years on things, and so definitely excited to talk about this topic. And I was able to join Dr. Reese's presentation, and I really like the format of people being able to drop in their questions and keep it informal and those type of things. We're going to spend time talking about what medications should we worry about, as we get older, and specifically if we have dementia, there's a lot of reasons we can be at increased risk of falls, right? And so medications can contribute, they're not usually the only reason, but they can be part of the reason, and it can be difficult to decide what things are we going to start, trying to deprescribe or reduce or assess if maybe these medications are adding to what some of our problems are. So first, we're going to kind of talk about falls as a geriatric syndrome and how frailty, maybe what meds might be adding to frailty in falls. Kind of look at if we're going to add certain medications, what are the monitoring parameters we can be doing as nurses, as caregivers, et cetera. And then look at what other medications could increase fall risk and how maybe we can be strategic on, doing that deprescribing, or maybe we add some other therapy to reduce some of those meds that might be increasing the fall risk. And so the thing about falls, it's like so many other geriatric syndromes that it just doesn't fit into a nice, envelope or box or whatever you might want to call it, that there's a lot of different things going on that are contributing to it. And so I think that's always for like my PharmD students, it's like thinking we can't maybe solve everything with reducing med or changing med and those type of things, but we got to start somewhere, right? We got to look at some of those modifiable risk factors and go from there. And so you can see as we age, there's a 50% chance that we're going to have one of these geriatric syndromes. And why we want to try and work on those modifiable risk factors is if we start adding more of those geriatric syndromes, that's going to really increase our risk of needing help with activities of daily living. So it's like we're adding caregiver burden, we're increasing our risk of needing home care services, all of a sudden needing assisted living, needing long-term care, all those type of things. And so the other way I sometimes like to think about with geriatric syndrome is looking at this graph and just thinking, like if we have high blood sugars or we have diabetes, it's usually that we have insulin resistance, or we have our pancreas is not producing, those beta cells are not producing insulin, and we end up with diabetes or increased blood sugars. Well, falls really falls under that geriatric syndrome where it's like we have all these different factors and pathways that are all interacting that are causing the issue. How this will sometimes come up in long-term care is, at our monthly or quarterly QAPI meetings, we'll notice that we'll have increased falls, and someone inevitably will say, Mark, let's do some of the meds and get rid of falls. And it's like, that's one part of it, but it's not everything, right? And so just another diagram kind of showing that, if we look at geriatric syndrome malnutrition, it's like we have a bunch of risk factors that we can't do anything about, aging, maybe the chronic disease they already have, but there's things that we can maybe assess whether we do something about. Are there medications that are adding to poor appetite, nausea, anorexia, those type of things? Is there some type of acute illness we can address? And so it's just thinking, that as we age, and especially some of our folks with dementia, we can become more frail, right? That we don't recover quite as well if we have stressors. If we get a pneumonia, we get a UTI, we get a viral infection, we don't kind of bounce back quite as well. And with our aging population, we're definitely seeing more people with frailty. Also, you add in as we age, we tend to, unless we exercise, very vigorously and doing weightlifting and those type of things, we can have some skeletal muscle strength reductions and those type of things. And that all adds to issues with balance and potential for fall and all of those type of things. What a lot of us wish we had is more guidelines on dosing of medications based on somebody's frailty, because we all know those 85, 90 plus year old people that are very active, and we still use the same medication doses we do in younger people, but that's not always perfect for everybody, and how we start out doses, sometimes we wish we would take that into effect. So I know, like the senior care pharmacists, have been trying to work on different disease states and things like that, to like, how do we maybe add in a frailty piece for dosing of medications, or maybe the top dose of certain medications, but we're not quite there yet. An area where I'm definitely not an expert, but there's a lot of things that go into frailty, and we have criteria to kind of assess for frailty, and so if we're noticing these issues going on the medication side, we should be thinking about, are there medications that are maybe adding to these problems, worsening some of these problems, and we maybe start backing off on those type of things. As we have more disability, diseases, cognitive impairment, risk factors, the geriatric symptoms like delirium, all these things increase our risk of frailty, and we'll kind of go through some of those meds that we should take particular interest in and trying to assess. There's also the frail scale, and so if we're a clinician or if we're a nurse and asking kind of those initial questions, what are some kind of simple open-ended questions that we can maybe work with our patients or the caregivers and somebody with maybe some more advanced dementia, and kind of assessing, do you get fatigued? How far can you walk? Have we lost weight and we're not necessarily trying to lose weight, to maybe kind of assess some of the frailty. And so that treatment and prevention is whenever we can get more people kind of assessing what's going on, so we don't miss, kind of what's actually happening in their home or wherever they're living at, and address, the illnesses that might be adding to it, or some of the medications. And so medications should be carefully reviewed. How long have they been on? When's the last time we've assessed them? A lot of times, some people tend to blame the providers and those type of things, but what you see so often is many of our seniors aren't making those appointments. They're not getting in to be seen and have their medications reviewed by their provider, not having them reviewed in their pharmacy or a PharmD, in the clinic, those type of things. And so it's really, we should be assessing, are these medications still benefits? Something we started 20 years ago. What's our life expectancy? Thinking through the shared decision making, deciding, is it worth the potential side effects for certain medications to continue them at the same dose? Along with that, sometimes as we age, maybe we have some decreases in our kidney function, and we should be looking at decreasing some of those medications. Dr. Reese talked about like the anticholinergic medications. We have some medications that are anticholinergic that are also maybe not getting cleared quite as well, and we should look at backing some of those off. Also, as we age, and for sure if we're have malnutrition, we can have less protein in our body. And there's certain medications that are highly protein bound. Kind of the classic meds that are highly protein bound are like warfarin or like phenytoin. And so what that basically means is if we have less protein, we have less, spots for that medication to bind to. And it's the medication that's unbound that exerts the therapeutic effect. And so it's easy, like in warfarin, that we can, we check INRs regularly. So we'll be changing those doses and those type of things. But something like phenytoin, we don't necessarily always check it quite as often. And that level's a little deceiving because regular phenytoin levels measure all the phenytoin, bound and unbound, or free phenytoin. So that's reasons that medications can kind of build up. Another maybe newer example, like the DOACs, the Pixaban, anticoagulants, they're also fairly highly protein bound. So there is a little bit chance um, of having higher unbound medication in the system. And so when we're talking specifically about frailty and those medication side effects, what are some of the meds that we should be thinking about and assessing whether they're maybe adding to the issue? So I always think of like SSRIs, and like Dr. Reese talked about the acetylcholinesterase inhibitors like donepezil. What is the dose limiting side effect of those medications? We don't start those medications low because we don't want to treat their depression quickly or try and have the most benefit as far as cognition, those type of things. We don't do it because we don't want to treat it quickly. It's to try and make sure that we actually tolerate it. The dose limiting side effects of those two classes of medications are nausea, anorexia, diarrhea, those type of things. And so, especially if the medication is new or it's recently increased, is that adding to why this person is having weight loss and adding to maybe even more muscle loss and those type of things, not getting adequate protein and those type of things. So those are times when maybe we think about, are we able to switch antidepressants? Those of us in geriatric psychiatry and long-term care, a lot of times we like mirtazapine sometimes because it has a little bit of appetite stimulation, also can help with anxiety and depression and those type of things. Other medications to think about are like iron. You see too often where people are iron deficient, get started on iron. Now, 2-3 years later, they're still on iron. Their hemoglobin's 13. Their iron stores are fine. It's like we should be looking at reducing and potentially stopping a medication that can also have some GI side effects. Another kind of newer class of medications to think about, and is obviously so popular right now, is like the GLPs. The semaglutide and those medications that are kind of almost touted as like miracle drugs, right? Because lose weight and have all these beneficial effects. But we do have to be a little bit careful in our older, more frail adults, even though they might have weight loss or have diabetes and those type of things, because they're quite sensitive to again, those dose limiting side effects. So you see a lot of people that get on GLPs and have kind of extreme nausea or extreme weight loss and those type of things. We maybe need to really evaluate whether people should stay on those medications long term or not. And there's getting to be more studies. They're kind of talking about that. So GLPs, there's definitely more studies going on and to maybe what things we should worry about but definitely with those GLPs, there's a lot of worry of that when we're losing weight, we're not just always losing fat, that we might be losing some muscle as well and maybe adding to more issues with sarcopenia. Some other medications to kind of think in this realm can affect taste and smell. So opioids sometimes and some other medications, especially if they're newer, we increase doses. Always be on the lookout for medications causing some of those side effects, and maybe we need to reevaluate them. Another classic kind of medication I think of as far as weight loss and nausea is digoxin. Doesn't get used near as much for heart failure or AFib as they used to, but we still have some folks on digoxin, and we usually like to live with digoxin levels that are a lot lower than maybe we did in the past. Usually we try and keep those digoxin levels below 1, and if we see somebody that's having nausea, weight loss, their pulse is running maybe closer to that 60 or below, it's like it's time to kind of reduce that medication and things and kind of rule it out as contributing to some of our problems going on here. And always, with so many of these geriatric syndromes, it's such a difficult thing because you're telling me, Mark, that the antidepressants can cause a problem, while also depression itself can cause part of that issue, and that's why we need our providers' help so much to really figure out, is this person, truly having depression? Are the non-pharmacy things not working? And then deciding, what medication would be best for that person. Also, there's some interventions that have shown benefit in frailty. And so some of them are fairly common sense when it comes to pharmacy type things. I think the big takeaway is vitamin D. Like so many vitamins over the years, we're never sure if it's good, bad, or whatever, because we see studies on both sides of it. My kind of takeaway is if in doubt, let's just check a vitamin D level, see where people are at. We forget sometimes that some of our folks don't always get outside and in the sun very often, or are using a lot of sunscreen, which is good as far as cancer concerns, but maybe we have a vitamin D level that is 12, that would be kind of an easy fix, and make sure that that's not adding to muscle weakness. And studies have also shown that reducing polypharmacy can help. And sometimes the best way to think about this sometimes is we have people with dementia that get put on hospice. All of a sudden we stop most of their medications. What happens? They rally. We have to take them off hospice, which is obviously a good thing, but it's like we wish we could have intervened earlier, right, in trying to reduce some of those medications. And so that's where we really need, the providers and caregivers and everybody to kind of come together to kind of decide what things make sense to kind of deprescribe and where to go from there. I also like this kind of diagram too, that kind of just shows what the issues are. If, all of a sudden we're not eating as well, maybe taking some of those meds I talked about, we're losing weight, we're losing muscle, we have less strength, well, all of a sudden we're at more risk for a fall and injury. And what does that add to? Well, then we're not as active. So it just sets up this negative feedback that we just keep on that downward trend. And so we got to try and intervene wherever we're at in this cycle to help that. So that leads us to falls. And we obviously know that it's a problem. Most of you, I'm guessing, work with a lot of geriatric patients or care for and those type of things. So you're not surprised by the large numbers. And some of the biggest things with falls and near falls is that then people become fearful of falls in the future. And now they're worried that it's like, oh, my provider is going to recommend that I sell the house and I move to assisted living or move to long-term care, or my family or friends are going to say those type of things. And it's kind of the opposite. If we have healthcare people involved, let's figure out why we maybe had falls or near falls, and we can work on some of those deficits and prevent those issues in the future. Because if all of a sudden now, because we're afraid of falling, we don't go out and exercise as much as we should, we don't get outside, we don't go to the functions that we normally, that's going to have a major impact on our quality of life and just add to depression and add to some of the things that add to frailty. And so, yeah, falls obviously, and the consequences, as we know, especially with all the data as far as hip fractures and stuff, how that can decrease people's quality of life, lead to loss of independence, and worse. So mobility is that important thing that can represent the difference if people are able to stay in their own home versus needing more and more assistance. And we know how much more that can cost families in the system and all those type of things. So once we start looking into falls, what to really focus on sometimes, was that fall provoked or unintentional? If somebody got pushed, if somebody had a seizure and they fell, if it was icy, that would happen to any of us, right? No matter how good our mobility and strength and some of those things. And it's much tougher, obviously, to deal with that. What we're really kind of trying to prevent is those unintentional and kind of unexpected falls. And so I'm guessing this group is pretty up on some of the risk factors, but as we get older, if we, use walkers and canes, that usually kind of shows that we have some types of deficits and increases fall risk. If we have had a history of falls and near falls, that's thought to increase our fall risk by 2 to 3 times. When it comes to alcohol use, literature kind of talks about trouble drinking, and in those studies, they talked about 14 or more drinks per week, which does seem like a lot, I guess, but that could increase risk. If people need to wake up a lot during the night, obviously, then we don't necessarily have our glasses or contacts, dark room, so that brings in a whole lot of other factors. But that's also somewhere to think about our medications contributing to some of those problems, or maybe the dosing of diuretics. We have them too late in the day, so medications could cause an issue there. Like we're talking about today, with people with dementia, cognitive impairment is a big risk factor, right? That we forget that we need a little assistance or to use our walker, and those type of things. We want to get somewhere, so we go, and so that can increase the risk. Stroke, obviously, post-stroke and muscle weakness issues can cause problems. People with Parkinson's, a couple different things, a little more risk for orthostasis, but for sure our gait issues, that we kind of shuffle our feet, so it's easy to trip. Our upper body sometimes can get moving a little faster than the bottom half. So a lot of reasons why Parkinson's can cause issues, and maybe kind of skipping ahead to medications. There's a lot of medications that can make somebody look like they have Parkinson's. Like Dr. Reese talked about risperidone, anything that's a good potent dopamine blocker. Those are good medications when people are having psychosis, hallucinations, real aggressive. A lot of times we want to block that dopamine, but we can make people look like they have Parkinson's. And so over the years, very often you'll come across people that get added on risperidone or haloperidol, and now a week or so later, we have nurses faxing, asking to work this patient up as far as having Parkinson's, and should we add Cinemet? And so again, whenever we're seeing a new symptom, we should always think about our medications adding to it or contributing, or maybe even the sole cause of maybe some of those symptoms. Muscle weakness. And so again, we talked about maybe vitamin D levels be something to think about. Not a whole lot of medications that add to muscle weakness, but one to think about, I guess, as far as older adults is statins. There's a lot of interactions that can increase our statin levels. And so if people are having a lot of weakness, having falls, we kind of ruled everything out, and we have that statin, it isn't sometimes the worst thing to check creatinine kinase, check and see if kind of muscle breakdown is adding to some of those issues. Vision issues, medications, not as much here, but again, we get too high doses of anticholinergics. That can cause some blurred vision. Mobility and balance problems. We'll talk a little bit more about cardiac issues a little bit later. And then one I think that gets forgot about a lot of times is anemia. If people's hemoglobin is too low, we're not getting enough oxygen to everywhere that needs it in the body. And so, especially our patients are on maybe that warfarin or DOAC or NSAIDs or aspirin, when was our last hemoglobin, just to make sure that it's like, oh man, I didn't realize our hemoglobin's 9, and that's contributing to maybe falls and those type of things. When it comes to medication, we got some more slides later, but just talking kind of through and how these medications maybe fit as far as the disorders above, benzodiazepines, sedatives, hypnotics, basically anything that crosses the blood-brain barrier really has the ability to maybe cause a delirium, make somebody have or look like they have cognitive impairment, and those type of things. So we're really always trying to reduce, not use benzos and sedatives unless we absolutely have to. I mean, I think about when I first started in with consultant pharmacy and things, over 20 years ago now, it felt like we used sleepers on almost everybody because we were just like trained that it's like, well, people are not going to be able to sleep. They move from the hospital to the nursing home, and they're, in the unfamiliar environment. No wonder they can't sleep. Let's put them on sleepers, and then they end up on there forever. Well, we know all the dangers of those medications, and we rarely use them anymore. And 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 we don't have any more sleep issues than we did then. That it's like, again, they're kind of more of a short-term fix. Antipsychotics, I really liked how Dr. Reese laid out like all the non pharmacy things, which again can be very tough to implement sometimes in different settings and those type of things. But it's like a medication shouldn't be our only thing that we do. And if we do use it, we got to use it at that lowest potential dose, because we can cause a lot of side effects. And here, falls a couple different ways. We can make somebody look like they have Parkinson's, like I mentioned, especially those potent dopamine blockers like risperidone or haloperidol. But we can also, with some of the antipsychotics, we can add to orthostatic hypotension. So the most common, probably one that gets used the most, would be quetiapine or Seroquel. Quetiapine, its probably main side effect in older people, even at low doses, is orthostasis. And so if people are all of a sudden getting dizzy, or it's sometimes if they're having falls, it's like, well, let's check one or two sets of orthostatic blood pressures. And if we have, a significant drop in systolic or diastolic blood pressure, we maybe need to assess whether we reduce the dose or maybe change medications, because that medication can definitely be adding to that. It's not an antipsychotic, but trazodone gets used frequently as a sedative or hypnotic. And trazodone, that's really its rate limiting or dose limiting side effect is also orthostatic hypertension. And so hypertension medications, anything that can affect blood pressure, for sure can cause orthostasis, add to falls. Diabetes medications. So anybody that's on insulin, or if they're on certain oral diabetes medications or multiple medications, if we have somebody that has falls or near falls, we need to know their blood sugars, and not just what is their 7 o'clock blood sugar every day because they take it once a day and that's the only time they take their blood sugar. If we're having falls in the afternoon or different time of day, that's when we need to check the blood sugars. If we can remember, after a fall, it's good to, when we're checking vitals, also check our blood sugars. And we've learned a lot over the years, right? As far as diabetes management. For a while, we wanted to be really aggressive, right? That we wanted people's A1C as close to quote unquote normal as possible. But we really found over time that having really strict, tight control in diabetes, especially for older adults, and especially those with dementia, we were causing more harm by hypoglycemia episodes, and for sure contributes to falls. And then again, that's where we need that interdisciplinary team and things, because we need help, from our OT friends and things, to also think about the environment and how some of those things can be also adding to falls. And so also our physical therapy folks will help us with some of the more complex, tests to figure out gait and balance and those type of things. And that's why I think the team approach can work so well, because some of my best referrals sometimes have been from physical therapy that's like, we've ruled everything else out. We can't find anything that's contributing, but I know they're on 20 medications. Is there something we maybe can do there to kind of reduce and not have as many falls? And that's been effective. And then vice versa, that it's like, if we're like, yeah, there's no meds that are contributing to problems, it's like we need, some help from PT and OT to kind of assess what else is going on. And so we'll kind of look through this kind of slide is just more to like remember all the different things that can go into fall risk, and we'll spend some more time on the medications coming up. And kind of those 3 questions to ask, because many times our seniors don't feel if we ask them directly, have you fallen? As a provider, that can be very intimidating. And again, their mind goes to, it's like, well, they're trying to put me into a setting where I don't want to be at, or they don't want me to be in my own home independently and those type of things. And so I think it's kind of shown that sometimes asking these questions, more open-ended questions about have you fallen the past year? Do you feel unsteady? Or maybe asking these questions, the nurses prior to, or having a questionnaire for caregivers to follow up prior can sometimes add to that. Trying to assess, how much of a workup we should do as far as falls. The CDC has the STEADY program, American Pharmacists Association and the CDC partnered, and has more resources for pharmacists and things as far as fall prevention, if people are interested in that. There was a deep prescribing study back in 2021 that found that deep prescribing some of these fall risk inducing drugs that we talked about don't necessarily help all by themselves. So I think that's a lot of times my reminder that it's like, we can't just only deal with the meds. We got to look at the patient as a whole and look at all those different modifiable risk factors. Yeah, and same thing. This slide kind of does that same thing, that it's like we have this geriatric syndrome, medications can contribute to a lot of the things on there, muscle weakness, orthostasis, and those type of things. But we need to work on as many of these modifiable things as possible. And so one thing to think about medications is, especially the cardiac meds and those type of things, they can increase our risk as far as syncope and having a large drop in blood pressure. And there's lots of different types. And so I think this is always my reminder that it's like, we need those referrals. Don't delay getting into your provider and kind of assess if we're having dizziness or big drop in blood pressure. We shouldn't just think, well, yeah, we can just adjust our meds at home, or talk to whomever to get our doses reduced and those type of things. There could be something a lot bigger going on. We could have the syncope that's more related to straining. Maybe med-wise there, it's like making sure that we're on appropriate laxatives and stool softeners and those type of things, so we're not straining during bowel movements. But that needs to be worked up. When it comes to orthostatic hypotension, like I said, if people stand up and they're dizzy, that's orthostatic hypotension. But also, if we check somebody's blood pressure sitting or lying, and then we recheck it after they stand up, if we have a drop in systolic blood pressure by at least 20, or the diastolic number drops by 10, that's significant. And that's, again, to go to our providers and see what we can do. And again, that's where PharmDs can help too, and maybe assessing some of those meds and giving ideas that way. Also, there's a lot of cardiac causes that can be a lot more chronic. And again, we need our cardiologists and internal med and other providers to help us out to figure out what we should do in those instances. When it comes to medications, they're usually can be responsible a lot of times for those acute causes of orthostasis. So are we on medications that are adding to dehydration, that maybe we have our diuretics a little bit too high, we're not to get enough oral intake? Maybe it's, those SSRIs that, we're having nausea and diarrhea and vomiting, and that's all leading to dehydration. And so it's not maybe directly the meds sometimes, but the side effects of those meds that are contributing to that. When we look at some of the cardiac meds that can be the worst, it's usually the short-acting meds, vasodilators, like, nitro type products, and volume depleters would, again, just be like those diuretics and that type of thing. And so, maybe it's a simple fix of someone's on, metoprolol immediate release and having some orthostasis. Maybe that's when we go to more of an extended release type of medication. Go to the the succinate formulation. Or maybe that's where people are really sensitive. That's sometimes maybe where they even do twice a day extended release medications, or trying to get by with very small peaks in that medication, right? And kind of split them up. And so sometimes that's the reason for that. And so, yeah, we kind of went through some of those symptoms, the dizziness or orthostasis, some other good things or tips to kind of remember. And this is from, as far as the references, this was a 2022 senior care pharmacist. It's, if people are having issues, especially after large meals, and all that blood's going to the gut to try and digest. And so we don't have, we're a little more risk for orthostasis. Eating smaller meals more frequently is a good thing. Really keeping people out of dehydration, trying to not strain, especially like with bowel movements and those type of things. And definitely the non-pharmacy approaches and adjusting meds are way more favorable versus adding some of the older time meds, midodrine or fludrocortisone. Again, if we've exhausted everything else and it's more of a chronic orthostasis, that's kind of where the medications are reserved for. And I do like this slide from that 2022 article that kind of shows all the different things that can go into falls. And in purple or lavender, you can kind of see the medications wrap around a lot of these different areas. And just a good reminder to look at what medications maybe we can reduce or get rid of. And so they did a huge meta-analysis of a lot of different studies and kind of looked at the relative risk of certain medications potentially contributing to falls. A lot of these things feel like common sense, but I think it's just good reminders to help us know where to go when we all of a sudden, maybe this person especially is new to us, and those type of things on what we try and reduce. So if people are on benzos, if they're on non-benzo sedatives like it's trazodone or the Z drugs like zolpidem, etc., what can we do to start tapering them down? Or what do we need to do? Maybe it's for benzodiazepines and anxiety and depression aren't being treated well without them. What meds could we maybe add that aren't without risk themselves, right? But maybe we try and increase our antidepressants and those type of things to get off or reduce those benzodiazepines that we know can contribute to problems. Antipsychotics, I think I covered most of the things there, that there is times when we need antipsychotics, right? We wish we had better drugs when people were aggressive, psychotic, hallucinating. And until we can kind of figure out what non-pharmacy things might help us and those type of things, we might need those meds. But we monitor for these side effects, and then we assess, are they improving? And maybe once we've stabilized, let's start, backing down, reducing those medications. Tricyclic antidepressants, thankfully we don't use those a whole lot in older people anymore because we have SSRIs and those type of things, but they also have risk of orthostasis and some have more anticholinergic activity than others. So that's where they can add to delirium. SSRIs, a lot of the risk they think with SSRIs, might be maybe the nutrition thing, but the other thing to think about is older people have a tougher time regulating sodium. And so if we have somebody that's new or increased doses of SSRIs, having confusion, maybe they're having falls, that's where getting, that BMP to be able to check sodium is a good thing and rule out that we don't have somebody that their sodium's kind of bottomed out, now it's in the 120s, and that's contributing to it. Antihypertensive drugs are definitely on that list. And so we usually, if people have trouble with dehydration, are we able to maybe steer away from maybe the diuretics if possible? It all is going to depend on what else this person has, another diagnosis and those type of things. We try to stay away from like the alpha blockers, unless somebody, we have a male patient with BPH, those type of things. What the kind of some of the deep prescribing guidelines say as far as blood pressure medications? Let's assess for those potential medications. Those providers that have worked in geriatrics a long time know them off the top of the head. If we're kind of newer or don't know about medications, that's where we maybe go to some of our references, whether it's the UK's stop start criteria, the US's Beers criteria to think about, okay, what medications should we kind of target to reduce or try and replace? And then, kind of some of the common sense guidelines, maybe we start with maybe just one of those medications, reduce it, really step up our blood pressure monitoring for a length of time, and then reassess whether we still need that medication. And I am not the expert when it comes to blood pressure measurements and things, but I think this is more of my reminder to really think about how low do we need somebody's blood pressure. There's some people that have a lot of risk factors going on, and there's maybe very good reasons for tight control of their blood pressure. But I think too often we have a lot of people that maybe they, quote unquote, just have hypertension, and we're living in systolic blood pressures at 100. Maybe times when their systolic blood pressure is below 100. That's where we need to kind of, what is the goal for our patient that's in front of us, and can we relax it, especially if we have risk for falls or had falls, and maybe helps us decide to deprescribe. And so I think that's really where we need, family providers, PharmDs, nursing to kind of come together and decide what we're going to do. And if we're really pushing it, it's like, well, then we maybe need to monitor our blood pressure and orthostatics a little bit closer than someone else. I included this reference that kind of, if people wanted a reference that kind of walked you through exactly deprescribing certain cardiac meds, that would be definitely a one to kind of save or pull that article and save it for future reference. Some other medications in that meta-analysis, and we kind of touched on a lot of them, is making sure that vitamin D levels are appropriate. That's going to help. Ones that we didn't talk about, laxatives, we talked about straining, and that could potentially be a risk for syncope, but we also need to think if we're really pushing the laxative doses and people are, maybe having some issues getting to the bathroom, have mobility issues, we maybe need to be a little careful with having too much of a laxative effect, right? People aren't able to get to the bathroom safely because we're kind of pushing the Miralax and Senna and et cetera a little bit too high. If you took one thing away from today, I would think just remembering to check blood sugars a little more frequently in people that are having falls, or assess, if we're on that sulfonylurea and that's the only diabetes medication, is that the safest one for our person with dementia that's at risk for hypoglycemia? Maybe not the best at eating their meals. You're not sure when they're going to eat them. There's a lot of oral diabetes medications that by themselves shouldn't cause hypoglycemia, and they potentially would be a lot safer. Another class of meds to really think about is those seizure medications. And like Dr. Reese talked about, sometimes we're using those seizure medications for non-seizure indications, using them for mood stability, maybe using them for pain and those type of things. Those medications can be adding to our dizziness, over sedation, and especially when you combine them with other medications that get the blood-brain barrier, whether it's opioids, whether it's anticholinergics, however, and so bringing that PharmD help to kind of assess, what things maybe we should kind of safely reduce. So Kimberly, I think that brings me to the case that I have. Let's see, I think we got a little bit of time here and stuff. And so in this case, we have a 68-year-old patient that lives at home, been on the same doses of citalopram, trazodone, and alprazolam for over 2 years. And we're saying depression, anxiety are stable and controlled. But we've noted dizziness and 4 falls over the last 6 months. No new medications in the last 6 months. So everything's been kind of chronic meds. We did a sitting and then a standing blood pressure, which show a significant drop, right? More than 20 systolic drop, more than 10 diastolic. Their usual blood pressure, it doesn't say how often, but it's usually in that 100 to 110 range, over 55, over 65. And blood sugars been ranging from 100 to 130, but we don't know when they were taken. And so let's kind of do maybe a chat storm, or people can unmute and say what maybe drug therapy questions or problems they might be having, or what other questions should we be asking? And I think there's a bunch of them, right?
Does anybody have any questions for the case? It's a false case. Thank you, Mark.
Or they can chat in. I put everybody to sleep, Kimberly. We didn't need medications. We used the non-drug therapy approach.
Well, I have a question.
Yes.
How is the person actually taking the medications?
Yeah, that would be
what's the medication adherence? I'd like to know that.
Yeah, that's a great question. Before we start coming up with lots of fancy ideas, sometimes just making sure that we're actually taking those medications. And then we don't really have many PRN medications, just a Tylenol, I guess. But then it's always good to say, how often are we actually taking some of those PRN meds? That's great. What else?
Monica says, what is the A1C?
Yeah, I think that's a great question. That it's like, then we can look, what's that blood sugar control over the last 2 to 3 months, kind of look at what our goal is. If this is somebody that's had diabetes long term, how tight a control would we want? So I think that would be great. And like I alluded to before, I think we check blood sugars, probably maybe 3-4 times a day for a few days to assess hypoglycemia. So I think that's great. Any thoughts, anybody on the glyburide, which is the sulfonylurea, as far as changing it?
Dr. Dillard says she has risks for hypoglycemia on the glyburide.
Yeah, I think that's perfect. I think with this person only needing one diabetes medication, it's like, I really think we should look at converting to, whether it's metformin, as long as renal function's okay. We could look at SGLT2s. Those are classes of medications that shouldn't cause hypoglycemia by themselves and would be a lot safer medication. Some of them might come with a little bit higher price tag, but they might, almost be cost effective if we're avoiding falls and those type of things. So that's great. What else do we have in there, Gunjan?
Amanda says, why is BP higher than normal?
Yeah, that's a great question. It's like, why is all of a sudden that sitting one higher than the usual? I'm not really sure. So maybe that goes back to this person really doesn't check their blood pressure very often. Maybe they don't have a cuff size or proper monitoring. Maybe they're using an electronic one that isn't calibrated, or who knows. So I think getting more blood pressure measurements would definitely be good. What's interesting as far as the case, if we just looked at it in a vacuum, it's like, appears like we're only treating hypertension. Probably could be somebody that we could look at deprescribing. And so if we're thinking and worried about dehydration adding to orthostasis, maybe that's where the diuretic, the tramterine hydrochlorothiazide, might be a good one to start tapering down on first. But I think you could make a good case for probably any of them based on getting some more results, right? Pulses and that type of thing. What else do we got in there, Gunjan?
A lot. Leslie says, is trazodone contributing to orthostasis? Is insomnia still a problem? Can it be managed with something else like melatonin?
Yeah, I think we got the A crowd today, Gunjan. That's perfect. Trazodone could be causing that orthostasis, so that medication should be reduced, especially when we're saying that we're not finding any problems that they're having issues with sleeping. So let's start reducing that.
Janet says white coat syndrome.
Yeah, that's a good thought of maybe why that one sitting blood pressure is a little higher like that.
Mhm. She may also need to be screened for substance abuse, alcohol, given the potential for disease-drug interaction.
That's great. Yep.
Could be prescribing cascade, amlodipine causing edema, so added diuretic, now orthostatic.
100%. Yeah, that what's the timeline of some of these medications being added? That's a common side effect in amlodipine is causing edema, and so then all of a sudden we add a diuretic on and add more problems. Another one that kind of goes in that prescribing cascade would be the citalopram. Interesting, it's dosed at night, which SSRIs for most people are activating. But again, anything that works in the brain can do the opposite. We know those people that we have to do the SSRIs at night. But it's like, did that add to some of the sleep issues? So I'd maybe be an advocate of trying moving that to the morning for a while, and also maybe be an advocate for increasing the citalopram as long as maybe the sodium's okay and things, to try and taper off alprazolam in the future. Or like my kind of favorite drug, mirtazapine, maybe we could try and treat some insomnia, anxiety, depression to help us taper off. Trazodone help us taper off that Xanax as well. So that would be some other things. So what other kind of trends are you seeing, Gunjan?
Can we try magnesium glycinate for insomnia and not add melatonin?
Yeah.
Is the sedative effect of trazodone linear? I have heard that at antidepressant doses, it is activating, so use it at a lower dose for sleep.
Yeah. What my thoughts on that is like mirtazapine, definitely at lower doses, you have more histamine effects. So at mirtazapine 7.5 and 15, you have more sleep, more appetite effects. But once you go to like 30 and 45, it's thought that the norepinephrine kind of overpowers that histamine, and you have less sedation, less like kind of appetite type of things. When it comes to trazodone, I think it is dose related as far as the orthostasis, but I could be wrong on that. But I think the higher the dose of trazodone, I think you can get more orthostasis. But great point to bring up.